Now, this happens to be one of my areas of expertise, and I've treated hundreds of injured athletes with ACL reconstructions, and quite often they're scared and they're nervous and they don't know what to expect, and we both do education in terms of trying to let them know what's going to happen. What I've found is most of the times these athletes will actually be better athletes after the whole process because they've gone through such an extensive program of relearning how to move, and they really get excited about that because that's something for them to look forward to. Now, let's get on to the surgical component of it. What is it that you do in basic terms to repair this structure?
I would say 99% of surgeries are done arthroscopically, minimal invasive surgery. And at surgery, we'll again look at the knee here, what you do is you have two portals. You make 2 half-inch incisions on both sides of the patellar tendon. And through that, you're able to look throughout the entire knee. Now, the surgery is done by, number one, you have to remove the torn anterior cruciate ligament, so that's debrided, and now you have to reconstruct it. You reconstruct it. There are many different ways to reconstruct it, but the basis is to create a bone tunnel. There's a little tunnel placed through the tibia that then enters the tibial plateau at the insertion. So you make a 1 centimeter or a half-inch tunnel, and then through that tunnel, you also make a tunnel up into the femur. So all of that surgery is now done through a small 1 to 1.5 incision on the tibia. Now, you then take a graft, you run a reconstructor within a graft. It can be an autograft from the patient, which means you can use some hamstrings. These are hamstrings over here tendons, or you can use portion of the patellar tendon or quadriceps tendon, or you can use an allograft, which is from another human being that has died, and certain parts of that parts of that person have been processed. Again, patellar tendon, quadriceps tendon, hamstrings, Achilles tendon, tibialis anterior posterior tendons from the ankle. Okay? So we have tissue to reconstruct it with. And what you do is you then place that tissue through those drill holes, okay, and then fixate the tissue in the drill holes. The bone now will then heal down to the tissue. That tissue is generally stronger than the anterior cruciate ligament that they had initially, and it heals. If you use allografts from other people, okay, it's better to go, I'm going to say male because they're stronger, like we've already talked about. Okay? And it's better to go cryopreserved, which means that there's a certain freezing process that doesn't change the fibers. They remain strong.
Now, the gold standard had been the patella tendon. Has that changed at all in the research?
It's not as common. I would say by saying the gold standard, with 95% of them all were done with the patellar tendon, which included bone off the patella and the anterior tubercle here, so I had bone on both sides. I would say it's probably down to 50% because we have these other structures that probably work just as well.
Yeah, and I found that the patient has less post-surgical pain when you don't take the patella tendon, and less risk factors for developing tendonitis when you don't use that. Is that correct?
Correct. I mean, yes, correct. You have to use a larger incision if you want to remove that, but there are also intra-articular things that during your surgery that you would do to stop that. Right. And again, in my experience, you work very hard not to have the athlete have patellar tendon pain after anterior cruciate ligament surgery.
Great.